Hi, this is Dr. Bhargava, and I have a few interesting cases to share with you. Our first patient is a 88-year-old male who presented with complaints of pain in the left thigh. X-rays had showed that he had a displaced fracture of the left femoral shaft, and then that fracture looked like a pathologic fracture, and so he underwent a CT scan. And here in the bone windows you can see the bone fragments and also sclerosis involving the proximal and the distal end of the femur. And then around this fracture in the soft tissue window we see this large heterogeneous attenuation mass. And so this patient underwent internal fixation, and at that time they did a biopsy and they found diffuse large B-cell lymphoma. And so the next step in their management was to get a FDG PET-CT scan. And so this is the rotating image from their FDG PET-CT scan showing intense hypermetabolism in the large mass that is centered around the femoral shaft where we had seen a fracture. And there was no other evidence of lymphomatous involvement. Some increased uptake is seen at the site of the greater trochanter, also seen here as a result of the internal fixation. And you can see here on this fused image that this mass is hypermetabolic and the femur has been fixed with a intramedullary nail. Here is an interesting article on this topic: Staging and Response Assessment of Lymphoma, a brief review of the Lugano classification and the role of FDG PET. Our next patient presented for a DEXA scan, and on the DEXA scan we see these labeled vertebral bodies in the lumbar spine: L1, L2, L3 and L4. At the site of L3 and L4 we see that there is extensive degenerative sclerosis leading to increase in the bone mineral density at this site compared to other vertebral bodies. So in this patient, if we report L1 through L4, the T-score will come to a category of normal bone mineral density. But that won't be right because this is artifactually elevated due to degenerative sclerosis. So here we want to go to other information that is provided and choose L1 and L2 and report that bone mineral density and the associated T-score and call it osteopenia. So remember, when you are looking at a DEXA scan, exclude the vertebral bodies that have degenerative sclerosis leading to artifactually elevated bone mineral density and the T-score, and include only the vertebral bodies that look normal. Our third patient is a 37-year-old male who presented with abdominal symptoms. They had a history of VP shunt placement, and a CSF cisternogram was performed after injection of technetium-labeled DTPA in the shunt reservoir, which is seen right here, and we see some activity going down the shunt into the abdomen. Inside the abdomen, on this 35-minute delayed image, we see linear increased uptake in the pattern of small bowel loops, and on the 1 hour delayed image we see small bowel activity, we see excretion into the urinary bladder, and also we see uptake or activity in the ascending colon and the descending colon. And so this raised a suspicion that the VP shunt has perforated through the intraperitoneal compartment into a small bowel loop. The next step was a CT scan, and here we can see that a part of the shunt is inside a small bowel loop, which is also seen here. That's the shunt catheter. It enters a small bowel loop right there, also seen inside the lumen right here. And so this patient underwent surgery and correction of this malpositioned catheter, and at surgery we can see that's a small bowel loop, and this is a catheter perforating through the omental fat into a loop of small bowel. And so such rare complications can occur when patients have a VP shunt with the distal end of the catheter in the peritoneal compartment. This is a good article on this topic: Abdominal Complications Related to VP Shunt Placement, a comprehensive review of literature. Thank you for watching.